Thank you. Thank you, BS. Is my screen visible?
Yes, it is.
Oh, so how do we decide the implant strategy in osteoporosis? So, as compared to a normal surgery, we tend to do certain variations in screws. We tend to put more screws. We tend to idealize them to get a better purchase and a better pull strength. There are certain screws available, hydroxyapatite coating. There are cement augmentation of normal screws. There are fenestrated or cannulated screws available. We tend to aim for vertical purchase with normal screws, and there are hooks, wires, and cables which are available. Now, there are certain screw designs which we need to keep in mind. Is the contact of screws with the bone is more important. So now if you try to increase the pitch depth, which means your core diameter of the screw is less, but your thread is quite more, which is how a cancellous screw looks like, your pull-out will become better. That in turn decreases screw strength. So that's why you need to sort of keep balance in between where you have to do. And because it's not only the pull-out strength, it's about the weight that the screws have to bear in cyclic load. The largest diameter screws you can put are the same. Again, we usually do not go more than 80% of the diameter of pedicle, because putting a screw more than that can cause a stress fracture of the pedicle. Then there are conic screws which are available. They are like self-tapping screws, are slight tapered ahead, then sort of become broad towards the rear end or the tube end of the screw. When you put these screws, you get a very good feeling that the screw is very tight. It's like good hold. That is insertional torque. It's not pull-out strength. If you have a conical screw, it toggles, it pulls, it is weakest in pull-out. So we have to differentiate between what we feel when putting in the screw versus a pull-out strength. So conic screws we avoid putting osteoporotic. Second is, how do we plan to put the screws? See that normally most of the screws are at 80% of the depth of the from the facet to the anterior vertebral body. If we consider this as 100%, if you put a shorter screw because the screw is touching end it or it's not able to negotiate it, reduces by 25%. Whereas if you are putting to the anterior cortex, you are getting 50% more pull strength as compared to a normal screw. This is lumbar spine. In thoracic spine, you get 75% purchase as you cross the concentric joint or the pedicle junction, to be more practical. Now, if you put an anatomical screw along the pedicle versus a circle straightforward screw in thoracic spine, that gives you an additional pull-out strength of 27%. So a straight surgical or a straight forward screw is preferred in osteoporotic spine. Ideally, do not tap them, but do not tap more than 1 mm. Never ever try to tap the same mm in these screws. And in these, cement injection increases the initial pull-out and fixation strength. Once it becomes loose, it is as good as a screw, as a normal screw. If you medialize more, you get a better purchase by around 28%, because you tend to lock in a wider portion and it's a triangular portion which will be more resistant to pull out. Now, if you burst a screw or if the screw is loose put in, there are certain options which you can do. Consider using a larger diameter screw. If pedicle walls are intact, they can accommodate a larger. If you are not able to do that, you have a size screw, you sort of try to change the trajectory so that you have two different things in which you are trying to go, the initial pilot hole and the second one. Consider cement augmentation if you are familiar with the technique. Keep that pedicle, use a wire or hook at that level and sort of go into the next level. Now, if you put in a screw and take it out and put it back again, you lose the strength by 34%. The largest diameter screw is the best. And looking at salvage, say a revision of 6 mm screw, if you put a 7 mm screw, you sort of get a 70% per. If you cement augment the 7 mm screw, you get significant sort of increase the pull out strength. And if your pedicle can accommodate a 8 mm screw, which will not be a very sort of common scenario, you will be able to put that big size. If you do, it is better than augmenting the same size. Now, we usually tend to cement augment whenever there are severe osteoporotic spine. This is a patient with 2-level osteoporotic fractures, multiple sort of severe osteoporosis and deficit. In this case, we used cement augmented screws, and they stayed back, and the patient went on to heal very well. Again, intra-body cage construction, something which we do instead of I find more forgiving. This is another with the central collapse with the critical deficit, and in this we did central body augmentation, normal screws. We had a small fracture. We put a short screw here. At one, she went to very well without any problem. Thread screw differential the cortic cancellous, and have been very use of screws, especially want to cement them. We to Jamshidi to the cement, then tap in the screw. If the porotic is involved, the discs along it, then you do a fixation, either short column or augment, and screw fixation be able to do for a long. Now, with screws, or if the very osteoporotic, we do now definitely because they are column fixation, the strength of thoracic has been pull out claw process pedicle. This is in spine. You choose a spine, you are this significant and this, so that is clause. They tend forgiving a very osteoporotic. This is a study where if the appetite is than 100 per ml, you sort of do not have age, have any fixed. Now, this study just by radio analysis had great or this vertebra with fracture, and then whatever you get, but now we have techniques to counter this. So in the is to solve this. Perhaps of bone density, mineral less than 3 gram square is recommended screw fix. Medical station fails, then which ultimate rescue is still. How is it sort of go along and it's moving? It's an A right test, and this is the thing which should rely. Now, there was a study done on 3 different type of sublaminar wires versus tapes and hooks, and the 2 things were studied: cutout strength and the stiffness of the construct. The thing was that the tape was as good as braided cable and was better wires in pull out strength. However, there was no difference in the stiffness of the construct. To conclude, I would like to say that to understand the stability pattern and plan treatment accordingly, do not make anterior reconstruction if it is needed. Keep multiple options available. You don't know what you may want to sort of use during surgery. Customized approach towards each fracture. Don't shy away from sublaminar wire. Old is gold, and especially very sort of old ladies, severe osteoporosis and very poor cover, it is got the least compared to screws, and do this on treating osteoporosis. Thank you very much.